Hi everyone, welcome to our Monty Hart lecture series. Today it's a great pleasure to have Dr. Matthew Davenport that will be speaking about evidence-based contrast media policies about the intravenous media. It's a great honor to have Dr. Davenport today here. He's the William Martel Professor of Radiology and Service Chief and Vice Chair in the Department of Radiology at Michigan Medicine. He is an internationally recognized expert on renal mass imaging and the safety and efficacy of radiographic contrast material. He has served on the U.S. Food and Drug Administration Medical Imaging Drugs Advisory Committee, the National Cancer Institute Clinical Imaging Steering Committee, as chair also as the American College of Radiology Committee on Drugs and Contrast Media, and vice chair of the ACR Quality and Safety Commission. So he's also founded and chairs the Radiology and Data System, the RADS Steering Committee for the ACR, and he's co-author on national policy statements with over 250 manuscripts, including journals such as New England Journal of Medicine, Circulation, JACC, Radiology, Annals of Internal Medicine, JAMA Internal Medicine, and you name them. His primary interests include patient safety, high-value care, and urologic imaging. So thank you very much for taking the time. We've been waiting for this lecture for a while.
Yeah, thanks so much. I appreciate the opportunity and look forward to the discussion here. I've got about 70 slides or so, and hopefully at the end we can chat a little bit about what we talked about. So these are my disclosures. There's nothing relevant here. I'll get this off the screen. There we go. So we're going to talk about contrast-induced acute kidney injury, how to prevent a hypersensitivity reaction, NSF and its potential relevance nowadays. We're trying to decide between doing a CT or an MRI. And then gadolinium retention, which is the accumulation of gadolinium in people's bodies, which is becoming, over the last 10 years, something that's talked about, and then the prevalence of immediate reaction. So the story of contrast-induced acute kidney injury is a very long one and goes back many decades. But in brief, the historic belief around contrast-induced acute kidney injury was based on correlation is not causation problems. So most of the studies on contrast-induced acute kidney injury took the assumption that if you had a bump in your serum creatinine after you got contrast, it must mean that there was a causal phenomenon at work and the contrast was hurting the kidneys. And what we've since learned is that in many cases is not true. And the extent to which it's not true is the unanswered remaining question. What we do know is that most contrast associated, meaning around the same time as, but not definitely caused by, contrast associated acute kidney injury is not caused by contrast media. But some of it might be. And the question is how much of it is. And much of this work of late has been happening for intravenous contrast media due to the availability of potential control groups, and it's starting to happen for intraarterial media. But for today's discussion, I'm going to focus on intravenous media like you get with a CT scan. Because of the problems around trying to establish causality from retrospective studies, non-randomized studies, there's been a whole slew since maybe 2013 or so of people trying to use propensity score matching or instrumental variable analysis to try to tease out the potential causal effect of contrast media in the absence of a randomized trial in which you take people and randomize them to get or not get contrast, but otherwise they're equivalent. And they have a range of outcomes here. There's a few from Mayo which showed that contrast media was not associated with acute kidney injury or any long-term outcome, which again is it's a really big statement. I mean, we came from AKI as a third most common cause of hospital-acquired acute kidney injury, 2002, from a NASH article, to now potentially saying maybe it's not associated with kidney injury at all. So pretty big difference there. Again, the correlation, not causation argument is one of the major reasons why. They did find in one of their studies that contrast media increased the risk of dialysis in patients in the ICU who had an EGFR below 45. There are a few papers from Michigan showing that contrast may be able to cause acute kidney injury, but only if the EGFR is less than 30. A few other papers saying contrast not associated with AKI. Another one saying contrast can cause AKI, but only if the EGFR is 30, and there's really many others. And so if we take third most common cause of hospital-acquired acute kidney injury to what this slew of papers is basically suggesting is many fewer patients are at real risk of acute kidney injury from contrast than what we used to think. Where we debate, where we're uncertain, is which patients may actually have risk and can we tease that out? And that's an unanswered question. And I'm going to show you an example of one of these more recent papers. This was published in 2020. Sample size was 22,000 overall. Of those, 400 had contrast-enhanced CT and an eGFR less than 30. They had 1,600 controls with an eGFR less than 30. Because it was not a randomized trial, they used propensity score adjustment to try and tease out any potential causal effect. And what they found is that as the eGFR dropped below 30, you started to see separation in which patients receiving contrast had a higher risk of acute kidney injury than patients who did not receive contrast. Now, a key point to these kinds of studies is just because you're seeing effect or non-effect in a propensity-adjusted retrospective study, you can't really take that and say, based on this evidence, there's no evidence of kidney injury, because propensity score adjustment really only controls for what you are actively controlling for, your known confounders that you're actively controlling for. It does not control for unknown confounders like a randomized design does. Additionally, almost all these studies do not meaningfully control for prophylactic measures that might have been taking place at the time, like giving volume expansion or modulating the dose or doing risk selection for the patients if they're unknown confounders that are being wrapped up into that. So you can't really say that the studies that are negative can be concluded as, contrast-induced acute kidney injury is a myth, but you really can say there's a ton of evidence now pointing towards the idea that the historically reported risk is very much overblown, and that has changed how we manage patients. It changes our risk-benefit calculation. It changes our decision at the point of care about whether we're going to go ahead and give that contrast-informed diagnosis or not. There's a study we published recently, and I did not choose to include it because of the audience, but it looked at patients who had abdominal pain, and they did or did not get contrast media. This was published in JAMA Surgery recently. And we tried to measure the effect on diagnostic accuracy of subtracting contrast media, the effect on diagnostic and accuracy of subtracting contrast media. And what we basically found is, after doing some control, is that you lose for abdominal pain patients about 30 percentage points of diagnostic accuracy when you withhold contrast. So when we're making that decision about, I'm nervous about their kidneys, I want to withhold the contrast, there is a penalty to doing that. And that penalty can, in some circumstances, be substantial. So what do we do at University of Michigan? Basically, we avoid iodine-based contrast material when the eGFR is less than 30 and or the person has acute kidney injury. Now, avoid doesn't mean don't give. So if it turns out that someone really needs it, let's say they've got concern for aortic dissection, and we don't want to do an MRI due to time reasons, and we need to do the contrasted study, and they have acute kidney injury, we just pick up the phone and have a risk-benefit decision. And as long as we think that the diagnostic benefits outweigh the harms, we will do it, recognizing there may be a risk of kidney injury in that patient population. So let's say we're in that situation, someone's got an eGFR less than 30, they're not on chronic dialysis, and we're curious about giving them contrast to make an important diagnosis. What's the number needed to harm of doing that? Well, in the studies that show an effect, in which they're not a null study, but we're showing an effect in those retrospective propensity-adjusted studies, it's about 1 in 6 patients would be harmed, meaning they develop kidney injury that's causally related to contrast media. Whereas in a patient population that you have no harm evident, obviously the number needed to harm will be infinite. So when we're having these conversations, it kind of sounds like this. This person has a potential risk of kidney injury caused by the contrast media. The number needed to harm is somewhere between 6 and infinity. So we can't say it's not going to happen, but it's also not going to happen in every single patient. For intravenous media, what about, prophylaxis now? This is a study from New England Journal 2018 in which there were 5,000 high-risk adult subjects randomized before angiography. And high risk in this context is not really high risk as I just presented to you. These weren't patients who all had eGFR less than 30 or acute kidney injury. These were people who were considered to be more at intermediate risk from intravenous media. And in this particular study, if you compared patients getting bicarb versus normal saline or acetylcysteine versus placebo, there wasn't really an observed difference in their major outcomes here, which was death, renal replacement therapy, kidney function decline, or contrast-induced acute kidney injury. Although in this trial, because there wasn't an unenhanced control group, we could call that contrast-associated acute kidney injury nowadays. So the message from this study was that acetylcysteine and bicarb are potentially not helpful. Now, there are tons of studies looking at the question of bicarb and acetylcysteine. There's many meta-analyses of bicarb and acetylcysteine, and there's probably meta-analyses of meta-analyses. And generally speaking, we consider bicarb to have a negligible effect and acetylcysteine to have a negligible effect when it comes to preventing contrast-induced acute kidney injury. And what about volume expansion? This is a study in which patients were randomized before iodine-based contrast media exposure. These people were also called high risk, but the eGFR was 30 to 59. So again, we would not really consider them high risk nowadays. But if you look at this here, this was a non-inferiority study in patients getting prophylaxis versus none with volume expansion. And the outcome was post-contrast acute kidney injury or contrast-associated acute kidney injury. In patients who had normal saline versus not, you can see there was really no difference between these groups, and non-inferiority was confirmed based on their pre-specified thresholds. Importantly, of patients who got normal saline, 1 out of 20 developed some complication from getting that volume expansion. Typically, it was around congestive heart failure type things. So no fluid was obviously cost savings versus saline because you're not doing anything, but you're causing more complications and you're not necessarily receiving a benefit on the back end in terms of a health benefit. So from this study, at least, they were arguing that really no prophylaxis for people with the eGFR 30 to 59 on a whole population basis. Now, it may be true that there's a person who has an eGFR of 31 and has 15 risk factors, and you make a wise decision and say, you know what, technically it's not below 30, but I'm going to make a judgment here as a physician that I'm a little bit nervous about them. When we do that, when we give that prophylaxis, just ask yourself the question, do they have risk factors that could hurt them from the prophylaxis? Like, do they have congestive heart failure, for example, in which giving that extra fluid could actually cause them harm? And this is kind of like a very abbreviated summary of some of the major thinking around this, is that we think that contrast-induced acute kidney injury is much less common. And I say, how common is it? So if you say, who's got an eGFR less than 30, not on dialysis, it's about 2% of inpatients and about 0.2% of outpatients. But based on these propensity-adjusted studies, instrumental variable analysis studies, we can't really conclude that it's a myth because the data are mixed and the prophylaxis has really not been accounted for. What we really need is a randomized trial, a formal randomized trial, in which patients are randomized to get or not get contrast media, in which there's clinical equipoise to give or not give contrast media. Today, we don't have it. Why not? For two reasons. One is that historically there was an ethical barrier to doing it, but I think now the ethical barrier is removed. The second reason why we don't have it is because to power a study to answer this question is very difficult. If you look here at the number of patients that are potentially at risk based on what we're learning from these studies, it's not that common. So there's been at least 2 studies I know of that have tried this and have failed due to accrual problems. They've just not been able to get enough patients accrued in which there's clinical equipoise to try and randomize and get an answer to that question. One of them was funded by a drug company and had like tens of millions of dollars earmarked to it, but they just couldn't accrue to the trial. Prophylaxis is generally, for intravenous media, not indicated if the eGFR is less than 30 and there's no acute kidney injury. So based on some of these data, the American College of Radiology and National Kidney Foundation had different guidelines. They were kind of making different recommendations about what to do. And this was an effort, this paper here, and it was a companion paper published in Kidney Medicine that is trying to get everyone on the same page. And I've highlighted Karen what's name who worked with me on some of these slides. So these are some of the major conclusions from that consensus statement. And when people ask me now, how should I manage a patient who's got kidney disease and I want to give them contrast media, intravenous contrast media, I basically direct them to this article, and there's another one on gadolinium media. So this paper endorsed the KDIGO criteria for how to define acute kidney injury and how to define chronic kidney disease. And I know everyone on this call is quite familiar with those, so I'm just going to skip forward. They also proposed new terminology. So instead of calling everything contrast-induced acute kidney injury, it's been relabeled now. And this is not just like verbal linguistic or verbal gymnastics, rather. This is intentional because we're trying to get out of people's minds that when you have acute kidney injury around the time of contrast, that it must be causal. We're disentangling that causality. So if we think about contrast-associated acute kidney injury, it's a correlative diagnosis, and it's actually very common, whereas true contrast-induced acute kidney injury is a causal diagnosis and probably is rare and requires a controlled study to answer that question. On any given patient, let's say in the course of clinical care, someone's given contrast media and you observe their kidney function declines afterwards, our ability to accurately diagnose that is terrible. And in fact, based on some modeling that we've done, you're accurate less than half the time, even in someone whose eGFR is less than 30, even when the risk is super enriched in that patient population. If we observe acute kidney injury happening afterwards and we diagnose it as contrast-induced, you're more likely to be wrong than you are to be right. So what is the risk of contrast-associated, in which there's no causal attribution, versus contrast-induced acute kidney injury? And you can see here that contrast-associated acute kidney injury is super common. And this is why for many years we thought that it was one of the most common causes of hospital-acquired acute kidney injury, was because of those numbers in that middle column. But based on the studies I've shown you and others, the risk of contrast-induced acute kidney injury is likely a lot less. You can see for eGFR less than 30, there's quite a lot of variation there, and that's because we just don't know, and the sample sizes have not been that great. So we still practice with caution when the eGFR is less than 30, not because we know for certain it exists there, but because we're uncertain and we want to err on the side of protecting patients. In general, if a necessary scan comes up, we should not avoid it purely based on the risk of kidney injury. And I gave you an example of like rule out dissection, in which you have a high pretest probability of disease. So who should be screened? Well, if you have a personal history of kidney disease, that's the only absolute indication of doing screening for the patient. So we ask them a series of questions like known chronic kidney disease, have you had acute kidney injury in the past, or kidney surgery or ablation? We look and see if they've got albuminuria. If that's true, then we will engage in our screening process, which is, do you have a recent evaluation of your kidney function? And we depend that based on their class. If they're outpatient, it's like within 3 months, and if it's an inpatient or an ED patient, within 48 hours. Other factors like diabetes mellitus, the patient's age, hypertension, other things, we don't screen patients just because they have those histories. Why is that a shift? So in the past, anyone who had any factor which could potentially be associated with kidney injury, we would screen them. And the reason why we've shifted that is because that resulted in way too many false positives. So now that we're looking for patients with eGFR less than 30, we're really dialed in on those who have the high pretest probability of having eGFR less than 30, and not the other folks who have a lower pretest probability of disease. So who do we consider to be at risk? And again, this is straight from those ACR, National Kidney Foundation joint consensus guidelines, is those who have active acute kidney injury or an eGFR less than 30, not on maintenance dialysis, or patients who are on maintenance dialysis and still making a lot of urine, in which they rely on that for their quality of life. It's somewhat debatable of people in the eGFR 30 to 44 zone who have numerous, and that was intentionally undefined, risk factors, and that ends up being at the discretion of whoever's ordering the test to make that call, recognizing that giving prophylaxis can have its own associated harms, and that needs to be taken into consideration. For many years, this came out in the early 2000s, potentially using iodixonol, which goes by the trade name Visipeg. It's an isoosmolality contrast media. Maybe you could reduce the risk of kidney injury if we do this. And essentially, through numerous studies, and again, meta-analyses of those studies, it's been concluded that the benefits of iodixonol with respect to kidney injury are not clinically meaningful. So if there is a benefit, it's not within the range of clinical significance. And so these agents are considered interchangeable. So we don't, as a routine, switch patients over to, for example, iodixonol if their kidney function is low. Who do we prophylax? Essentially, if they have acute kidney injury or the eGFR is less than 30 and they're not on dialysis, then obviously, we would just, in radiology, we discuss this with an ordering provider. And then as ordering providers, you all would sort of make that call. And if the eGFR is 30 to 44 and numerous risk factors, that would be entirely up to the referring service. But in general, it gets overdone. In general, we overgive that. Does kidney replacement therapy lower risk? In other words, if we do a contrast-enhanced CT, and should we start them on dialysis or something? And the answer obviously is no. We shouldn't initiate dialysis or alter dialysis based solely on giving someone iodine-based contrast material. And the nephrologists who are on this panel felt particularly strongly about not changing dialysis prescriptions based on contrast administration. This comes up too is someone has a congenitally solitary kidney or they have a kidney transplant. Should we change the guidelines? And functionally, according to these recommendations, the answer is no, we shouldn't change our guidelines. We're still going to make our decision based on the person's eGFR, just as if they had 2 kidneys. We're not going to necessarily modify the risk based on that. Sometimes it comes up where someone has, kidney function that's low, and we're going to give them contrast, like the dissection example I gave. And a technologist or a nurse or a physician says, well, should we just lower the dose? We're planning to give 120 cc's. Why don't we give, 70 sounds good today. And in general, we should only do that if it's part of an established routine at the health system. So if you have in your health system a plan and we're going to dose adjust on this basis, and we know that dose adjustment still results in a diagnostic exam, that's one thing. But making an on-the-fly decision to reduce dose is not recommended because you could end up with a non-diagnostic exam. And that will be the worst case, did you expose someone to risk with a not a diagnostic result. In general, the belief is that if you think you can get away on average with 80 cc's instead of 120 cc's, then you should just give everybody 80 cc's, not just give 80 cc's to the person who's got kidney problems. And that's something that the group felt pretty strongly about. Of course, if someone's on nephrotoxic medications and you have acute kidney injury and eGFR less than 30, not on maintenance dialysis, we would want to withhold those, but that should be happening probably anyways. And in pediatric patients, we use a similar risk estimation. And an important point here is that, the data in peds is even worse than it is in adults because children typically don't get CT as often as adults do. And so the sample size in adults is weak in eGFR less than 30. The sample size in children is weak with the eGFR less than 45. Otherwise, all the data basically lines up similarly between children and adults. One of the differences here is that there's a different formula that's used to calculate eGFR. And as many on the call likely know, is that there's an effort now in medicine to remove race from clinical calculators. And this was a statement that came out in 2021 about taking race out of the GFR estimation. And that's something at Michigan Medicine that we do. Our calculations no longer include race. So I'm going to switch topics briefly and talk about preventing reactions. And then once I speak about that, I'm going to go back and talk about NSF and loop in some of the context around NSF and how it relates to iodine-based contrast material when trying to estimate people who have kidney disease. So let's say you got someone coming in, they've got a history of a contrast reaction, and you're like, okay, do I give them premedication? Do I avoid contrast? Is this even important? Some of the major evidence around steroid prepping came from the 1980s and 1990s. And I'm not going to go into the weeds on the trials, but these are the only two randomized trials that have tried to address this topic. And the high-level summary of them is that they have no high-risk patients. Both of them enrolled average-risk patients. The 1987 study used old agents that we don't use in clinical practice anymore. And the 94 study had insufficient power. They were, even if they did work in the 94 study, the sample size was very tiny. And this has since been estimated that the number needed to treat to prevent a reaction of significance is enormous. And I'll show you some evidence about that. So those are the only two randomized trials we have, and they both have pretty substantial limitations. I'm going to show you some of the more modern evidence, but it's a retrospective. In this study, this was on inpatients. There were 1,400 prepped versus 1,400 non-prepped who were matched by age, sex, and year of CT and had similar rates of 13 major comorbidities. And when you give someone a 13-hour oral steroid prep in the hospital, you significantly delay, that's a causal statement, they're associated with a significant delay in time to CT of a median of 25 hours. So you're basically frame shifting forward the time to diagnosis, which might not be that big of a deal if the person's going to be in the hospital anyways. Like, what difference does it make? Maybe it's no problem, but you can see that it actually contributes to a longer length of stay. So again, patients who get prepped with a 13-hour oral prep in the hospital, they also, coincidentally or not, have a longer length of stay of a median of 25 hours. And they also have significantly more hospital-acquired infections. This is not a randomized study, but it raises some questions about if you're giving someone a long prep, are you frame shifting forward time to diagnosis and time for someone to get out of the hospital, which we know is important. Asking the question, does prepping inpatients, these long oral preps, hurt more than it helps? And this is some modeling that was done using those data and some others around the risk of a contrast reaction based on the base case scenario, trying to prevent a single lethal reaction with a 13-hour oral regimen, trying to prevent a single lethal reaction, added hospital length of stay to 162 years worth, contributed a bunch of extra cost, and was associated with an increased risk of hospital-acquired infection-related deaths that dwarfed our effort to prevent that single reaction. So why are we seeing these kind of gaudy numbers here? These are probably wrong numbers, but it's at least raising the question because the effect size of a PrEP is very tiny. And the likelihood of a severe reaction is also tiny. And when a severe reaction happens, the effectiveness of using epinephrine to treat it is high. So when you daisy chain all that stuff together, the probability that you're going to have a severe reaction causing death or significant morbidity is quite low relative to the potential harm of giving these PrEPs. So this is a subsequent step in that modeling exercise where we said, let's assume that all the variables we put into our analysis are the rosiest. They're the nicest. They're like, the least harm, the most benefit, that kind of stuff. In this model, greatest efficacy and least harm being the assumptions, you can see at the bottom there, associated with more deaths than you actually are preventing by giving these long oral steroid prep. So raises the question, do you need like a long oral prep as an inpatient? Maybe not, but what's the evidence base for rapid preps? And there's basically one study on this. This is a study, again, it's non-randomized. It's a 5-hour IV prep versus a 13-hour oral prep. This is non-inferiority was the power calculation here. There were 1,000 people got a 13-hour prep and 370 got an accelerated prep. And you can see here the breakthrough reaction rates were pretty similar, and non-inferiority was supported based on the pre-specified threshold. So about 2 to 2.5% of people are going to have some kind of breakthrough reaction. That's a statement that's agnostic to the severity of the reaction. Many of those end up being mild. So at least from this study, a 5-hour intention to treat rapid IV prep is non-inferior to a 13-hour oral prep in that retrospective design. But is it non-inferior to no efficacy? So that study can't comment on whether it's working or not. It just says that you're getting a similar outcome. So this came out in 2021. It's a retrospective study of 1,900 high-risk patients getting 4,300 doses of contrast. And I just want to focus, right here. This is a comparison. You say people who got the same intravenous contrast media, meaning like last time you got Isoview and this time you get Isoview. Whether you did or didn't get steroid premedication, your odds ratio in this study was 1, which means there was really no evidence of efficacy taking place by giving someone a steroid prep, which is a pretty striking statement. And this is if you switch the contrast agent. So last time they got Isoview, and this time I'm going to give you iodixonol or something. If you switch the agent, you can see the odds ratio goes substantially down. In this study, it dropped by 74% to 84% of the risk of you having a reaction by switching the agent. Historically, we thought about contrast media reactions as a class effect, and now we're increasingly strongly realizing that is not true. And certain agents will repeat their reactions, and if you can switch the agent to a non-reactive agent, you end up doing okay. So at least in this study, they're saying that preps may not work at all in high-risk patients. And switching agents seems to have a large effect size. So can we just, stop giving steroid preps? I'm going to show you some of the guidelines that are out on this topic. This is from the European Society of Urogenital Radiology. They state premedication is not recommended because there is not good evidence for its effectiveness. It's a pretty strong statement. That's different to what's commonly done in the United States, but that's what's being done in Europe. This is a 2020 Joint Task Force Allergy and Immunology statement. We suggest against routinely administering steroid preps to prevent anaphylaxis in patients with prior contrast media reactions. But they said their certainty rating was very low. And they said higher certainty evidence is needed to better inform practice. This is the American College of Radiology's guidelines. Premedication may be considered. That's kind of a soft language of you can do it if you want to. If you've had a prior contrast reaction of unknown type or hypersensitivity reaction to the same class of media. And in general, an accelerated prep is recommended in patients who are ED or inpatients because those long oral preps are probably not helping people. At Michigan Medicine, we've converted every inpatient prep and every ED prep to a 5-hour IV prep because the 13-hour preps are really not supported by the evidence, and they're potentially associated with some collateral harm, and they just result in delayed diagnosis, and we don't think there's reason to do that. That's our regimen that we give as our 5-hour prep. And we have observed this to be a helpful practice change. The ACR goes on to talk about changing contrast media, and they say it may help reduce the likelihood of a subsequent reaction, and the effect size of switching agents may dwarf that of premedication alone. So this here is a study looking at that specific question. This came out in 2022. It's a meta-analysis on switching agents. And you can see the studies there on the left-hand side and the summary statistic down there. And basically, if we're going to switch agents, you can attain a risk ratio of 0.39. So you're going to dramatically lower potentially the risk of you developing a contrast reaction if you just simply switch the agent. So if you have someone who's coming in who's had a prior reaction that's meaningful, like a prior, severe reaction where someone was on an epi drip or something, and you're like, okay, what am I going to do with this patient? Obviously, you can talk about using a different imaging exam or removing contrast entirely. But one thing we've started doing now is we've asked our allergists and immunologists to weigh in and do testing on the patient. This is now widely accepted in Europe. If you've had a severe reaction, to do testing. And if you are not reactive to a different agent, you can just go ahead and give that other agent instead. If I'm reading the tea leaves, the strength of recommendation for switching agents is likely to continue to increase and the strength of recommendation for premedication is likely to continue to decrease. And it would not surprise me if those get phased out entirely, and instead what we use is just simply changing the agents. I'm going to switch now to NSF because it ties into the original discussion we had about patient has kidney injury, chronic or acute, and we want to know what to do with that patient. So after 2007, when NSF became popularized, there were 3 agents that were recognized to be contraindicated if the eGFR was less than 30. They're called Omniscan and Optimark and Magnivis. I'm not going to go into the chemistry behind these, but they're kind of slightly different chemistries behind these 3 agents here. So in general, we don't use these anymore. And if at your hospital you're using Omniscan or Optimark or Magnivis for a contrast-enhanced MRI, you probably should stop doing that. However, there are some agents which have very few, if any, cases of NSF, despite giving many doses. And those are multi-HANTs and all the macrocyclic agents. And we call these agents together collectively class 2 agents. So if you're someone talking about a class 2 gadolinium-based contrast media, that's those agents being lumped together. I'm not going to go into the chemistry, but you can see they do have slightly different chemistries. In general, macrocyclic agents wrap a cage around the gadolinium ion and protect it so that it's less likely to dissociate from the chelate. Free gadolinium is toxic. So in order for us to give it to patients and image it, we have to wrap it in a bunch of other stuff so the gadolinium doesn't break away and cause interaction with tissues. There have been a bunch of single center studies looking at the incidence of NSF for high-risk patients using a low-risk or class 2 gadolinium-based contrast media. So this is a high-risk patient getting a class 2 agent, and you can see that the risk is pretty favorable. I mean, in these studies here, there was really no observed risk of NSF. And those data were summarized in this meta-analysis looking at patients who have the eGFR less than 30 who are getting a group 2 gadolinium-based contrast agent. And the observed risk of NSF was 0, and there was about 5,000 patients included in the study. And the upper bound of the 95% confidence limit of risk, I think about it as the James Bond number, 007. So if I'm counseling a patient about the risk of NSF or talking to a referring service about risk of NSF, if the eGFR is less than 30 and I'm giving a group 2 agent, I will say the risk of NSF, I can't say it's 0 because you can never prove a negative, but it's somewhere between 0 and 0.07% is a risk of NSF. So the practical significance of that is that because that is so low, we change our behavior now around how we give group 2 agents and how we counsel patients and referring providers. If you compare that to the number needed to harm I mentioned earlier of as low as 6 for iodine-based media and someone who's not on maintenance dialysis when the eGFR is less than 30, it starts to push you towards thinking, probably a contrast-enhanced MR is a better option if somebody is not on maintenance dialysis and they still have nephrons that could be harmed by giving iodine-based contrast media. This is from the American College of Radiology's manual on contrast media, which are guidelines that most radiologists follow. And you can see here they're talking about group 2 agents now and saying that assessment of kidney function is optional before giving a group 2 agent. And again, they're not saying that the risk of NSF is 0. They're just saying that your risk-benefit calculation is not likely to change by doing screening, so don't necessarily spend the time doing that. The FDA still recommends screening prior to all GBCAs, so this is technically off-label with respect to NSF risk. That being said, many institutions have converted to this, including my own, and we don't do kidney function screening for group 2 agents because we think it is safer for patients and a better use of resources to do it this way. There's a kind of agent called a group 3 agent, which you may not use very much, but a group 3 agent is only one of them. It's called Eavist or Premedivist or gadoxetic acid, and it's used for liver imaging, often to find like colorectal cancer metastases or used to differentiate focal nodular hyperplasia from hepatic adenoma. But the reason why it's considered group 3 is because there's much fewer patients who've been exposed to this. In this particular study here, this meta-analysis had 4 studies, but only 106 administrations. They observed 0 cases of NSF. Using a similar rubric to what I described for the prior study, their upper bound confidence limit was 2.8%. And that compares to that group 2 upper bound of 0.07%. This is another study that came out after that one, 160 administrations of group 3, no risk of NSF. Again, the confidence limit's a little bit on the high side. So right now, this remains a group 3 agent, and we still do consenting for this, and we still make sure that the person's understanding risks and benefits. For group 2, we do not. So let's say you've got a patient who's got acute kidney injury or eGFR less than 30, and you want to know, like, what do we do? Do we give them gadolinium-based media or iodine-based media, or do nothing, do something different? So in general, if we deem that contrast is necessary, and we think, for the sake of argument, that CT and the MR in this case are going to be diagnostically equivalent, this is sort of the rubric that we use. If they're not making any urine and they're on maintenance dialysis, we would do a contrast-enhanced CT because there's no risk of contrast-induced acute kidney injury, and there is potentially a tiny risk of NSF. However, if they're not making no urine and on maintenance dialysis, then we would prefer to do a contrast-enhanced MRI instead with a class 2 agent because the risk of NSF is so tiny and the risk of contrast-induced acute kidney injury is ambiguous. And if we're giving a group 2 agent, we don't do screening or informed consent because, again, it wouldn't change our risk-benefit calculation. So I showed you the ACR and National Kidney Foundation consensus statement for iodine-based media, and this is the same kind of statement. This is now for gadolinium-based contrast media. And again, this is my kind of go-to document for these kinds of queries. So if you're doing a contrast-enhanced MR, maybe a cardiac MR, for example, this is the document you would think about. So we group gadolinium-based media into 3 categories based on risk. I mentioned group 2. I mentioned group 3. Group 1 are those 3 agents I said was the highest risk for NSF, which is Optimark, Omniscan, and Magnavus. And in general, these are not really used nowadays. Who is at risk of NSF? It's patients who get a group 1 agent, especially at double, triple, quadruple doses, and also have severe kidney disease. And what does that mean in the context of NSF? It's patients who have kidney replacement therapy, like peritoneal dialysis or hemodialysis, et cetera, or acute kidney injury, or who have stage 4 or 5 chronic kidney disease. What is the risk of NSF if you're getting a group 2 agent? It's, again, somewhere between 0 and 0.07% if you're getting a class 2 agent, and that would be multi-Hansen, all the macrocyclic drugs. Who should undergo kidney function screening? Well, in general, we screen patients who are getting a group 1, if we're using that at all, which we probably aren't, or a group 3 agent, but we don't do so for patients getting group 2. When does a radiologist call someone? According to these guidelines, if you see a patient that comes across your desk, and when should we call the referring provider and say, we should discuss this? Again, if it's group 2, we're probably not going to make a phone call to let you know, because again, it's not going to change the risk-benefit calculation so long as the contrast media is indicated. There is no known prophylaxis for NSF, regardless of what grouping of GBCA you're using. Pretty much all you can really do is await for kidney function recovery before you give the drug, or using a group 2 agent instead. There are some who believe that by doing dialysis to remove the gadolinium, you can prevent NSF from happening. And that's to date not been shown in a study. It is true that if you do dialysis, you can remove gadolinium from the patient. That is true. But it's never been associated with a decreased risk of NSF. And because of the potential harms of changing the dialysis prescription, what this group has decided is that we should not initiate dialysis or alter dialysis based solely on giving the gadolinium-based contrast agent. And again, the nephrologist felt particularly strong about this point. GBCM, or gadolinium-based media, can be nephrotoxic if given in high off-label doses, especially in animal models, but using normal on-label dosing, it's not a relevant clinical concern. What about giving a bunch of doses kind of spaced together? In general, if the scan is indicated, we just do it. We don't do that. We're not necessarily worried about NSF from that. If you can delay it and you want to make sure all the gadolinium is cleared out, the half-life of this is about 2 hours. So in terms with a normal kidney function, about 2 hours. So after 4 or 5 half-lives, we consider it to be gone. Let's say the person's got kidney impairment. If you wait more than 24 hours, you're probably going to be okay to give that second dose. We don't change our recommendations based on someone also getting a CT scan or they have nephrotoxic drugs on board or chemotherapy. We still do the same exact things. And just like with iodine-based media, for pediatric patients, we're using the exact same recommendations. And one thing that some people don't realize is that there is no known reported case of NSF in children who are 5 years of age or younger. I mentioned earlier gadolinium retention and what is the significance of that. So that when you do, like, let's say a contrast-enhanced MR or an MR angiography or something, some amount of the gadolinium you give somebody is going to stick around in their body. And if you organize all the agents we have had on the market here into the NSF grouping, which is on the left-hand side, and which ones have gadolinium retention, which is on the right-hand side, you can see that gadolinium retention has been observed on imaging studies in pretty much all the linear agents. And what that means is if you took an MRI of somebody's brain and looked for T1-weighted signal changes in the deep brain nuclei on patients who've received repeated doses of gadolinium media, if it's a linear agent, it's observable with the eye. If you do post-mortem studies where you resect brain tissue and analyze it at the chemical level, all the agents actually are associated with gadolinium retention that can last for months or years. The macrocyclic agents do so about an order of magnitude less than the linear agents. What fraction are we talking about here? Is this a lot of gadolinium or a little bit? It's a tiny amount. It's like single percentage point or less of the administered dose ends up being retained in the person for months or years. And also what's relevant is how is it complex and what is the reactions happening? It's a local environment. And what we've seen in these postmortem studies is there's not really evidence of cellular injury or harm that's happening from it, but it remains a topic of active research. So people have tried to answer the question of what is the clinical importance? And here's a few studies that tried to get at this. This first one here was published in JAMA in 2016. It was a retrospective cohort of over 200,000 patients all over the age of 66. They focused on Parkinsonism as their outcome because of the nuclei that are involved in this gadolinium retention, and they did not see a signal there. This was a prospective cohort of 4,000 patients, mean age was 72, and this was in the Mayo Clinic study on aging, in which they had tracked, cognitive outcomes over time, and they found no evidence of neurocognitive harm. And then this study was an uncontrolled study, also published in JAMA in 2016, looking at 1.4 million pregnancies that did or didn't get an MRI with or without contrast. And they observed that when gadolinium contrast media was given, that the fetus had an increased risk of inflammatory conditions, stillbirth, and neonatal death, but they did not control for the reason why the exam was done. And in general, we consider gadolinium to be relatively contraindicated in pregnancy, and we don't give it unless there's a compelling reason. So it's hard to know if those patients were associated with a higher risk because they were being given in extenuating circumstances. The FDA has been releasing statements about gadolinium retention. Essentially, the conclusion is there's no scientific evidence of harm. There are class warnings. So if you open up the package insert, you can see there's a class warning related to this. And patients are given handouts explaining, in legal terms, like, those long, small font stuff about what can potentially happen as a consequence of getting gadolinium exposure. And one of the things that's mentioned is gadolinium retention. And when people are choosing agents, we do actually consider the retention characteristics of the agent as one among several important factors that are considered when choosing which agent to give. In 2018, there was a consortium of specialties at the NIH looking at how to move forward on this topic related to gadolinium chelates. And basically, the conclusion was it's not clear how important this is, but due to the absence of evidence, we need to pursue it. And the industry was essentially motivated to conduct a prospective study evaluating the significance of this, and that is ongoing. And then the last topic with just a few little slides here is on immediate reactions. I just wanted to show this here to show that in patients who get gadolinium-based contrast, you can see that the risk of a contrast reaction is about 10-fold less than getting an iodine-based contrast agent. And certain agents, which I'm not going to go into the weeds now, have a higher associated risk of reactions than others. And one of the interesting quirks is that the agents that are at the lowest risk of NSF have the higher rate of reaction and vice versa. So patients who have agents that have a low risk of NSF tend to have a higher risk of reaction. So they kind of have a flip there. What about breakthrough reactions for gadolinium-based media? Basically, steroid preps do not seem to work for gadolinium-based media. And when we've looked at this in different ways, the breakthrough reaction rate is like 4 out of 10 people end up having a breakthrough reaction, when you give them a steroid prep. So there's dubious evidence around giving steroid preps for iodine-based media. It's especially weak for gadolinium-based media. And there's really no study which has shown that giving a prep to someone who's got a contrast reaction to gadolinium-based media actually improves outcome. So switching agents may have a benefit, but it was not analyzable in the study due to low power. So if we just summarize kind of what we've talked about The risk of contrast-induced acute kidney injury remains uncertain when the eGFR is less than 30. I've talked about some guidelines and some approaches, some clinical ways of thinking about this, about what to do, whether to choose, a CT scan or an MRI, and what risks and benefits to think about. That uncertainty ranges from 0 to 17% when the eGFR is less than 30. Number needed to harm as high, or as low rather, as 6. The risk of NSF from a group 2 agent is that's a 007 number I try to remember when I'm trying to counsel people. Upper bound of risk is 0.07%. And the observable cases are 0 out of around 5,000 or so. The risk of NSF from that class 3 agent I mentioned is small, but we need more data. And we know this gadolinium retention is occurring, but it has unclear importance. And we try to inform patients using a handout. And breakthrough reactions are very common. And I didn't go into the weeds on this, but when someone has a breakthrough reaction, it typically is a similar severity to the index reaction. So if someone had a severe I almost died reaction, and we give them a steroid prep in the hopes that we're going to prevent something, that is not a reassurance, because if they re-react, it's probably going to be severe. So if we have a severe reaction, we prefer either to avoid giving that contrast agent, or we ask allergy and immunology to do some testing on them if the time permits. So thank you very much. I hope that was somewhat educational, and I'm happy to try to answer any questions if you have any.
Thank you very much. That was wonderful. I learned a lot, and I'm sure everyone has as well. I'm going to share you should see there the code for the CME. And let me just stop, pause share. Okay. So let's go now to the questions, and please put your questions in the Q&A. I have to stop sharing here, but okay, let's go through the questions, put them in the Q&A. I'll start with one. Any difference on the intravenous versus intra-arterial administration of contrast?
Yeah, great question. There's not a lot of strong evidence to this. There was a study published in Radiology within the last 5 years or so that tried to answer that question. And what I'll do is I'll pull up that article while we're talking. But basically what it showed is that the risk of kidney injury was higher in patients who were exposed to catheter angiography than it was to patients exposed to coronary CT angiogram. And my memory is that that was a randomized trial. And that the risk of acute kidney injury was higher in those who were randomized to get the catheter angiography. Now, one of the differences, between IV versus IA administration is, the route that you're administering it. But if you think about it kind of logically, if we're not doing, ventriculography, we're putting a bunch of contrast into the, arterial system. If you're really kind of, peripheral, like in the coronary arteries, from the perspective of the patient, it may end up being largely an intravenous administration. So then you say, well, why would there potentially be a difference? There are other factors. So if you're putting a catheter up that potentially could be, showering atheroemboli, for example, there may be causes of kidney injury that are not related to the contrast, but are related to the procedure that's happening to the patient. Atheroemboli being one potential explanation for that. But my memory is that in that particular study, it's the only one I know about, when patients were randomized to get one or the other, that was the outcome.
Thank you very much. That was great. So from Mark Menegos, interventional cardiologist here, director of one of our cath labs, he says NCDR data suggests that contrast-induced nephropathy or kidney injury is not as low as the numbers that you've shown here, but he says a large part of the problem in these patients may be the comorbidities, especially in patients, but the contrast gets the blame. This association versus causation. Any extra comments on that?
Yeah, I mean, I completely agree with what Mark said, is that our estimates of risk are based on the best data that we have, which is not that great. And the best data we have is on these kind of they're large studies. They have more than 10,000 subjects included in them, but they're essentially propensity matched or instrumental variable analysis kind of matched studies. And it's, we can only measure those known confounders, and we're not taking into account, prophylaxis measures. And it could be that the risk of kidney injury is higher. Exactly where that estimate is, or that risk estimate is not totally clear. And I would say we need to have a robust, significant study that meaningfully answers the question. But like I said before, it's really been challenged by accrual. And to get patients who have eGFR less than 30 with equipoise and to randomize them, it's just been a struggle to get that over the finish line. But I agree with the point. And because all these, we published a study like how often does someone have a confounder once their eGFR is less than 30? It's basically 100% of the time. Every single one of these patients who had eGFR less than 30 and in the context of they're sick, which is why they're getting the contrasted scan in the first place, 100% of them basically have some other issue that's kind of mixing it up. So the randomized trial is needed to really get at that. I agree.
Great, thank you very much. From our fellows, they say, great talk. Should we be doing the Meran score for contrast-induced nephropathy routinely prior to cath, even in patients with low normal GFR? Do you even recommend a score for estimating risk?
Yeah, I want to be careful not to overstep because I'm not a cardiologist, and I want to be careful not to overstep on that. I know a lot of folks are using scoring systems to decide risk and also using scoring systems to decide how much contrast media should be given and setting like ceilings on that. Like if the score is this, we're going to cap out at this amount of contrast media. And I know I think scores are also being used to decide what types of prophylactic measures are used and how much volume expansion to give, for example. But I'm nervous about commenting on that specific point. I don't want to step outside my area of expertise.
No, thank you. Thank you very much. So in patients that get a CT, so if the GFR is above 30, even if it's reduced, so we shouldn't probably change the dose at all, like you're saying, right?
Yeah, if the person does not have acute kidney injury, so stable kidney function, and the eGFR is above 30, we change nothing. We do exactly what we would do otherwise. Let's say the person's eGFR was 24 and it's stable, it's 24, and the ER orders it because the person has some problem. We would observe the 24. We would call the ER and say, I see Mr. Smith here has a low eGFR. We consider the risk to the patient to be non-zero of developing kidney injury from the contrast. The risk is somewhere between number needed to harm of 6 and number needed to harm of not harmful. Are there alternatives that we could do in this patient, or is this something that we really need? We have a small discussion. And if it turns out that there is no better test and we really need to do it, we say, okay, we're going to proceed. And in that context, we would just make a little note and we would not alter the contrast medium dose for that patient. And the intent here, again, is to use the minimum diagnostic dose. And if we feel that the minimum diagnostic dose is actually lower than what we're doing on a daily basis, well, then we should just change our protocol to be the minimum diagnostic dose for everybody, as opposed to like overdosing all the other patients. So the belief is we should not do ad hoc lowering of contrast media dose. The risk-benefit trade-off there is the worst outcome is you do something in which you're not totally sure what it's going to look like, and then you do it, and you've exposed them to risk, and like you end up with a washed-out study or the contrast bolus is missed or something, and that would be the worst outcome. So we prefer not to do that.
Thank you very much. And I think just to end, a similar question on gadolinium, single versus double dosing, just to wrap up. What are your comments on that?
When we gave double, triple, quadruple doses in the olden days for MRI angiography in patients who had kidney, this is a classic story, was like someone has concern for renal artery stenosis. Why? Because their kidney function wasn't great. And we want to evaluate whether renal artery stenosis, they can do a stent. That was kind of the old school way of thinking. And because they couldn't do a contrast in SCT because they were so nervous about contrast-induced acute kidney injury or CIN in the olden days, we would do an MRI angiogram and do a double, triple, quadruple dose using one of those older agents I mentioned, those class 1 agents like Omniscan, Optimark, Magnavist. And those particular patients were the ones who had the highest risk of NSF, extra doses on top of what they were getting. Now that we've moved to group 2 agents, whether you're giving multi-HANS or one of the macrocyclics, we are not observing cases of NSF in that cohort. I mean, if we are, it's less, single digits. So if the question is, can we double dose someone getting a group 2 agent and be safe? The answer is probably yes, but I can't give you a 100% answer because we don't have a cohort of patients who are getting double doses of a group 2 agent with eGFR less than 30 to answer that question. The whole world's population of people exposed to A class 2 agent with eGFR less than 30 is about 5,000, and that was circa early 2000 or so. And of those, to parse it down, say who got a double dose, we're talking about a tiny, tiny, fraction of patients. So if the double dose is believed to be necessary to make a diagnosis, like with, cardiac MRI, for example, and the belief is the diagnostic advantage is there, and you believe in it, think it's necessary, my argument would be, if you're going to do the test that's accurate. Since we're not seeing a strong safety signal there, and you need it from a diagnostic standpoint, my advice would be that if you believe it's necessary, then to do it. I'm not well versed in cardiac MR diagnosis in terms of, that's just not my space, about whether single dose versus double dose diagnostic accuracy difference. I don't know. But if you've made the conclusion that the diagnostic accuracy difference is real and it's meaningful and it's going to help your practice, my advice would be to do it, because we don't see a strong safety signal there for NSF, and you're doing it for a legit reason, which is somebody's heart. So that would be my approach. I don't recommend doing, but some folks know that, if you give gadolinium-based media, it does weakly attenuate X-rays. So some people in the past would say, well, I can't give them, iodine-based media for an angiogram, so I'm going to give them a huge dose of gadolinium and do like an angiography with gadolinium. Don't do that. So some folks were doing that. They were giving like 70, 80, 90 cc's of gadolinium to try it. Don't do that.
I've seen those studies, yeah.
Yeah,
Okay.
yeah.
Okay, thank you very much. This was a master class on contrast. We've learned a lot, so I really appreciate your time.
Yeah, my pleasure. Absolutely. If anyone has any questions and want to send me a note, feel free.